You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for May 31st, 2024. This week, we're talking the FLOW trial of semaglutide. The DanCavas cardiovascular screening trial is back, non-invasive tests for chest pain, and conflict of interest on social media. First, I want to say a big thanks to the group at Beth Israel Deaconess Medical Center in Boston. I gave cardiology rounds there last Friday, and it was a huge honor to speak at Harvard Medical School. A podcaster at Harvard. That is something. Thank you to Dr. Peter Zimmetbaum and others for the invitation. We had a great discussion about critical appraisal and trials, and I learned a bunch from them. This weekend, tomorrow in fact, I fly to Manchester, UK to attend and speak at the British Cardiovascular Society annual meeting, and I'm looking forward to meeting many of my friends in the UK. First topic today is semaglutide for patients with chronic kidney disease. This is the FLOW trial. Semaglutide has won again. The FLOW trial was a large renal outcomes trial of semaglutide versus placebo in patients who had both CKD and type 2 diabetes. Now, CKD patients have 3 proven renal protective drugs already. These are the RAS inhibitors, SGLT2 inhibitors, and finerenone. The authors of the FLOW trial tested yet another one, the GLP-1 agonist, semaglutide. Now, keep in mind, though, that renal outcomes in CKD patients are much less common than cardiovascular outcomes. So the FLOW trial also had important cardiovascular outcomes results. Patients had to have CKD. The definitions of CKD are quite complex, especially for an old school cardiologist. I will say them once. Now, CKD was defined by a GFR of 50 to 75 milliliters per minute per 1.73 meters squared of body surface area, and a urinary albumin-to-creatinine ratio with albumin measured in milligrams and creatinine measured in grams of greater than 300 and less than 5,000, or an estimated GFR of 25 to less than 50 milliliters per minute per 1.73 meters squared, and a urinary albumin-to-creatinine ratio of greater than 100 and less than 5,000. The trial procedures included randomization stratified according to SGLT2 inhibitor use, which was about 15% in both arms. And remember that the FLOW trial began enrolling patients many years ago before SGLT2 inhibitors were so common. The trialists used an 8-week dose escalation of semaglutide. The primary outcome of FLOW was major kidney disease events. This was a composite of the onset of kidney failure, which was dialysis, transplantation, or an eGFR of less than 15, at least a 50% reduction in eGFR from baseline, or death from kidney-related or cardiovascular causes. Pre-specified confirmatory secondary outcomes were tested hierarchically. These included a total eGFR slope, which was the annual rate of change of estimated GFR from randomization to the end of the trial, B, major cardiovascular events, which was a composite of MI, stroke, or CV death, or C, death from any cause. The results. This was a big trial at nearly 400 sites in 28 countries. The screen to enrolled ratio was quite good, where more than half of those screened were actually enrolled. There were slightly less than 1,800 patients in each group, age 66, 1/3 women, average BMI 31. The mean eGFR was 47. Slightly more than 2/3 of patients were at, quote, very high risk of kidney disease progression. The mean hemoglobin A1C in these diabetic patients was 7.8, and about 95% of patients were on RAS inhibition 80% were on a lipid-lowering drug, and I mention that because remember that any of these gains are on top of pretty good medical therapy. FLOW trial was terminated early after an interim analysis noted benefits. The median follow-up ended up being 3.4 years, and semaglutide clearly won. For the primary renal endpoint, it was 5.8 versus 7.5% primary endpoint events per 100 patient years in the semaglutide versus placebo arm. That's a 1.7% absolute risk reduction. That translates to a 24% relative risk reduction, hazard ratio 0.76, with confidence intervals going from 0.66 to 0.88, so highly significant. Over 3 years, the absolute risk reduction was 18.7 versus 23.2%, so that ends up being a 4.5% absolute risk reduction, which translates to a number needed to treat of about 20, which is a certainly clinically significant effect size. Lower risk with semaglutide was also observed for a composite of the kidney-specific components of the primary outcome. Here, the hazard ratio was 0.79 and statistically significant. It was also positive for death from cardiovascular causes. Here, the hazard ratio was 0.71, so a 29% reduction in CV death. The results were similar in all subgroups, yet the hazard ratio was much more impressive in those not on SGLT2 inhibitor versus those on SGLT2 inhibitors. It was 0.73 versus 1.07. As for the three confirmatory endpoints, they too were all positive. The slope of the decline of the eGFR was better in the semaglutide arm. The risk of major cardiovascular events was 18% lower in the semaglutide arm. Here, the hazard ratio was 0.82, again with significant confidence intervals. One peculiar finding was that the rate of CV death drove the benefit. MI was lower in the semaglutide arm and stroke was slightly higher. It's curious because there are two major drivers of CV death, right? And the risk of death was 20% lower in the semaglutide arm. I'll come back to that in the discussion. And I know you're going to ask about change in weight. Indeed, the mean reduction in body weight was 4.1 kilograms better in the semaglutide versus placebo arm. Hemoglobin A1C was also lower in the semaglutide arm. Systolic blood pressure was only 2.2 millimeters of mercury lower. There were safety outcomes. Adverse events leading to the discontinuation were more common in the semaglutide arm. It was 13.2 versus 11.9. And this finding was driven mainly by gastrointestinal issues, as you'd expect. So my comments. FLOW was clearly a positive trial. It stopped early for efficacy. Semaglutide reduced the rate of progression of CKD. It lowered CV outcomes and it reduced weight. Patients with diabetes and CKD surely benefit from semaglutide over placebo. One question that the authors discussed and that I wonder about is which order to use these drugs. Right? RAS inhibitors, SGLT2 inhibitors, and the non-steroidal mineralocorticoid receptor antagonist finerenone have all shown renal protective properties. The authors argue that GLP-1 agonists should be used early because, quote, although studies of SGLT2 inhibitors in patients with CKD have clearly identified important benefits with respect to kidney outcomes, the findings regarding effects on cardiovascular events and death from any cause in the population have been mixed. And I went back and looked. The credence canagliflozin and dapakidney were quite positive for CV death, but empakidney not so much. I realize, of course, that GLP-1 agonists are costly, but we now have outcomes data in patients with diabetes, in patients with CKD and diabetes, and patients with obesity and established cardiovascular disease. And we know the drugs reduce weight, even more than weight loss surgery. My one caveat and question with FLOW is, and I hope future studies sort this out, is why or how did the FLOW trial show a 2.6% absolute lower rate of CV death and a 0.7% lower rate of MI, which is nowhere near as much, and a 0.7% higher rate of stroke? What, I wonder, drove the lower rate of CV deaths? Was this an adjudication issue? I don't know. I am asking, and I look forward to future clarifications. Still though, for patients with obesity, diabetes, and CKD, semaglutide clearly provides statistically robust and clinically important effects in addition to patients on RAS inhibition. Okay, next topic is the Dancavas trial has published results at 6 years. Authors of the Dancavas cardiovascular screening trial have a new, interesting post-hoc study that's published in the journal PLOS Medicine. Now, Dancavas is about the only screening RCT that I consider clearly positive. Positive because the primary endpoint was all-cause death, not a disease-specific cause of death like most cancer screening trials. I will spend time on this trial and post-hoc analysis because I see Dancavas as one of the most unique and important cardiovascular trials in the last decade. It overflows with learning points. The main trial was published in the New England Journal of Medicine in 2022. It was a population-based RCT of a package of cardiovascular screening tests versus standard care. It's important to point out that the two arms of Dancavas were invited to screening or standard Danish primary care. Patients were between 65 and 70 years old, and they were only men. In Denmark, all Danes have a national email, so the authors were able to randomize in a 1-to-2 fashion to be invited to screening or not. Patients in the screening group could elect to come to screening or they might not. They were obviously not blinded. Patients not invited simply did not know they were in a trial. The screening program is super interesting. It included a non-contrasted CT to look for coronary calcium and aneurysms, and that's it. They did AF screening, ABI, blood pressure, and blood glucose and cholesterol. The primary author, Dr. Axel Didrikson, told me that all of this was done usually after hours in a clinic. There were no radiology overreads for the CT. This was very, very streamlined screening. Positive findings were acted on. Lipid-lowering therapy and diabetes meds, as well as a referral for AF or aneurysms, were done according to the findings. Approximately 45,000 men underwent randomization, about 16,000 in the invited group and 29,000 in the control arm. But only 2/3 of those actually invited underwent the screening. And to the author's credit, they analyzed the results according to the 16,000 invited, whether or not they had screening. This was an intention to screen versus no invitation comparison study. And I think this is so important. It is unlike the Nordic colonoscopy screening trial where they actually looked at those who were screened, like the per protocol analysis. The Dancavas authors address this point and they write in this new paper, quote, "Due to the high likelihood of healthy user selection bias, unadjusted comparison of outcomes among those who actually attended the screening and those randomized to usual care would be highly inappropriate." Highly inappropriate. Okay, the main trial results. This was the 2022 paper in New England. They found that after a median follow-up of 5.5 years, 12.6% in the invited group and 13.1% in the control group died. That hazard ratio was a tantalizing 0.95, with 95 confidence intervals that went to 0.90, a 10% reduction, to 1.00, no reduction. The p-value was 0.06. Stroke was reduced by 7%, MI by 9%, aortic dissection by 5%, and aortic rupture by 19%. There was a bit of controversy back in 2022 about interpretation of the primary endpoint. The New England Journal of Medicine made Dr. Didrikson and his co-authors write that the trial was negative. But the hazard ratio went from 0.90 to 1.00, and this was all-cause death. So if you went with the, say, protected TAVR trial interpretation, the conclusion of Dancavas could have equally included the phrase, quote, "On the basis of the 95% confidence intervals, the results may not rule out a benefit of the cardiovascular screening program." This would have been a 10% lower mortality benefit if you used the lower bound of that confidence interval. All right, now to the new post hoc paper. Here they looked at 6 years of outcome data. It was 5 years in the main paper. But there was another novel twist to this post hoc analysis, and I like it. The authors decided on a primary endpoint by asking patients what they valued most. They sent out a survey to a random group of about 9,000 patients. The two highest ranking outcomes from the patient survey was MI and stroke. So that was the primary endpoint for this analysis. So 10.8% in the invited to screening group versus 11.5% in the usual care group experienced an MI or stroke. That hazard ratio was 0.93, and the 95% confidence intervals went from 0.88 to 0.98, and so the p-value calculated at 0.01, which was significant. The number needed to be invited to screening, however, was quite high at 148. They also included in this analysis a secondary MACE outcome of stroke, MI, heart failure, CV death. This was positive as well for screening, a 6% reduction that made statistical significance. Another composite endpoint they called the MALE, M-A-L-E. This was major adverse limb events such as dissection or rupture of the aorta, revasc due to limb ischemia, amputation due to PAD or CV death, and this showed a 9% reduction, again statistically significant. They noted that the initiation of antiplatelet and lipid-lowering agents was increased in the invited to screening group, while there were no differences in the initiation of anticoagulants, blood pressure, or diabetes drugs. Elective aneurysm repair was more common in the invited to screening groups. It was 0.9 versus 0.6%. Now, rather than looking directly at those screened, which was a per protocol analysis, which they say would be highly inappropriate, they did an inverse probability treatment weighting analysis to sort out those most likely to accept screening in the two groups. It's hard for me to totally understand this methodology, but I think it's a way of matching those in the control arm versus those in the active arm who would have had screening. It's like a propensity score. It's like a conditional probability of attending screening given pre-screening characteristics. This also yielded a 13% statistically significant reduction in the primary endpoint of stroke and MI for the screening group. There was a safety outcome we should talk about. For intracranial bleeding, it was 1.9% versus 1.7%, so 0.2% higher in the invited to screening group. That tiny difference, however, calculated to a 17% higher relative risk increase, and it was statistically significant, hazard ratio 1.17, with 95% confidence intervals going from 1.02 to 1.35 and a p-value of 0.03. Severe GI bleeding was not statistically significantly different, 5.9 versus 5.8%. Okay, so my comments on the 6-year results of Dan Kvass. First, I wrote about the main trial in 2022, and I'll link to it. I noted at the time how unique this trial was. First, this was not coronary calcium screening. It was a comprehensive package of very efficient screening. It was done after normal clinic hours. It was a quick CT scan, was done only for measurements by a technician. During the scan, they did a rhythm strip for AFib, they did a blood draw and a blood pressure, and the patient was home in short order. This is Denmark, so there's no culture of coronary angiography and stress testing in asymptomatic people, and as such, there was no increase in PCI or CABG in the invited to screening group. And the take-home for the 6-year results was that if you do such a screening in an environment like Denmark, you can reduce cardiovascular outcomes. Now, the reason for the reduction in cardiovascular events may be a slightly higher use of antiplatelets and lipid-lowering drug, or it may be a behavioral change. Behavior change from discovering abnormalities or meeting a kind and caring person such as Axel Dietrichson. It doesn't matter why there were better outcomes, and that's the beauty of trials. It doesn't matter why. If a trial shows there's benefit, there's benefit. Now, in the paper, the authors make note of a higher rate of intracranial bleeds. On the surface, this seems like a counterforce against the benefit. But I don't think it's super relevant because the rate of intracranial bleeding is fortunately very low. The rate of MACE outcomes was actually 30%. In that range, the rate of intracranial bleeding is less than 2%, and the delta was only 0.2%. The journal PLOS Medicine has the authors include a major limitation in the abstract, which I really like and I wish more journals would do. And here, in this case, it was the fact that Dancavas was restricted to men between the ages of 65 and 74. The results, therefore, do not generalize to women or men of other age groups. And I discussed this point in my 2022 column. The reason Dancavas authors chose this select patient group is that this age group of men had the highest rate of cardiovascular events and the lowest rate of competing risks. Women, they argue, would have had such a low rate of cardiovascular events that screening would have had little chance to reduce outcomes. They even did a pilot trial showing this. Now, that enrollment decision provides a shining example of how most trials select highly specific groups of patients. And this is not nefarious. It's common sense. It's why you don't see lots of frail, elderly patients or patients with end-stage renal disease in most cardiac trials, because these patients have too many competing risks of outcomes. It's also why cardiology trials enrich their patient population with patients likely to have a cardiac event. For instance, the Odyssey Outcomes trial, the PCSK9 trial of alirocumab, included post-ACS patients, and the SELECT trial of semaglutide, including patients with obesity who had established cardiovascular disease. The point is that trials need to include patients who are at risk of having the primary endpoint that's going to be studied and not too high of competing risks. Our job as users of the evidence is to smartly consider who was in a trial, what was the trial environment like, how clinically important were the results. Dancavas requires really smart thinking for translation. Now, in translating this result, I have a science hat and my American clinician hat. So science-wise, Dancavas is notable because background care in Denmark is already quite good. I mean, they have universal health care, public health system. So the highly unique screening program won against an already good comparator. But using my U.S. clinician hat, these results do not translate to the U.S., wherein all CT scans would be overread by a radiologist, which would lead to a flurry of incidentalomas like pulmonary nodules and pulmonary nodule clinics. Also, U.S. CAC scans often lead to stress testing, angiograms, PCI, cabbage-type cascades, which is another drain on efficacy and cost efficacy. It's a drain on efficacy because there are numerous trials showing no benefit to revascularization in asymptomatic coronary disease over medical therapy. Finally, I absolutely love the take of the Dancavas authors in strongly stating how wrong it would be to look at only those who receive screening, because clearly those are different types of patients. Now, this was not done in the Nordic trial of colonoscopy, and it allowed the gastrointestinal associations to provide talking points that colonoscopy screening works if you get it done. But even then, there was no difference in overall death in the Nordic trial. So kudos to the Dancavas authors. All right, third topic is stress testing for chest pain. Now, this was a paper from authors in the Kaiser Permanente network looking at emergency department referral for non-invasive testing patterns in patients with chest pain. The first author was Dr. Dustin Mark. This was an observational study, but the authors looked to associate 2-year hard clinical outcomes, MACE outcomes, and referral patterns. MACE here was defined as MI, cardiac arrest, shock, or cardiovascular death. This is a really important question because A, chest pain is a common presentation. B, you don't want to miss a life-threatening coronary lesion. C, numerous trials show no benefit to revascularization in stable coronary disease. D, non-invasive testing often picks up incidental coronary disease that is unrelated to the chest pain. And E, non-invasive testing is costly. Circulation Outcomes published a retrospective cohort study that was done in 21 emergency departments over 6 years. Now, these were all non-MI patients. If you had a STEMI or positive troponins, you were excluded. They set up interesting groups to compare. So they grouped patient encounters by the non-invasive cardiac test referral rate of the initially assigned emergency department doctor and relative to the local peers. So there were low, intermediate, and high referring doctors. They also looked at how the heart score of patients correlated with outcomes. It was a large study, 144,000 patients. They were 58-year-olds on average. More than half of the patients were women. The rate of non-invasive cardiac test referral at 30 days was 13%, 20%, and 28% in the low, intermediate, and high non-invasive cardiac test referral groups. Patients in the three non-randomized groups were well balanced according to baseline characteristics, and the big results compared with the low referral group, there was no significant decrease in the adjusted hazard of MACE within the intermediate or high referring groups. Now, actually, the hazard ratio was a little higher in the high referring and intermediate groups, but after adjustment, it didn't make statistical significance, but it was not lower. Now, some have criticized this analysis because it was simply looking at referral patterns of doctors, but the authors write that the actual non-invasive cardiac tests were higher, 53% versus 33%, in the high versus low referral arm. In addition, the authors also analyzed outcomes according to the heart score. The heart score puts patients into low, moderate, or high-risk categories. Here, there were also no differences in outcome among low versus high referral patterns. So, my comments. First, not only was there not an association for benefit for high referring doctors, there was also actually a trend toward harm from being an intermediate or high referral, though an adjusted analysis did not reach significance. And it's observational, and I would not suggest harm. But I do like this paper. It's a bit of a quasi-randomized study, right? Because who a doctor sees, whether they see a low, intermediate, or high referring emergency department doctor, is a bit random. And there was not an association in better outcomes in those who referred more, even when considering higher heart score patients. And the other positive baseline characteristics were matched. Now, the lack of association makes sense to me, right? It fits because think about chest pain without troponin elevations in the modern era. Troponin assays are so sensitive that if there is no elevation, it is almost certain that the chest pain is not heralding an unstable acute coronary syndrome, which is the point of risk stratification test by any means, be it functional or anatomic with CTA. The vast majority of non-invasive cardiac testing in this study were stress ECGs or perfusion scans, not anatomic tests. Now, referral patterns not associating with better outcomes also make sense because any coronary disease picked up will surely be incidental given the negative troponins. And if coronary disease is incidental, therefore it is asymptomatic and revascularization would have no benefit over medical therapy. Now, I know what you're thinking. I realize the Scott heart proponents out there will say that picking up disease, even if incidental, is beneficial because diagnosis of disease will cause initiation of medical therapy, especially since these were pretty young 58-year-olds. And indeed, that was the argument as to why CTA scans in Scott heart were found to be beneficial, though I am not sure because Scott heart had a really outsized effect size. In this analysis, there were slightly more medical therapy started. That could be a positive, but the Scott heart benefits did not replicate here. But of course, I, like the authors, have to acknowledge the limitations of this non-random analysis. We should be just as skeptical of observational studies that find no association as we do ones that find positive or negative associations. That said, I'm sorry, but I think we do way too many coronary evaluations in troponin-negative patients with chest pain. I think this would be a great area for a government-funded or a PCORI-type pragmatic study where we randomize high-sensitivity troponin-negative patients to non-invasive cardiac testing or no non-invasive cardiac testing. Okay, final topic, and I'll be short here. This is on conflict of interest in social media. JAMA itself has published yesterday a research letter on industry payments to doctors who endorse drugs and devices on social media. It's a small study led by a Sloan Kettering team. First author is Sonia Perswad. As background, the first sentence is eye-opening. Quote, physicians commonly receive financial payments from industry totaling, sit down for this, $2.46 billion in 2022 alone. Now, the authors used drugs approved in 2021 and 2022, and they basically linked each doctor to Open Payments website. The social media platform studied was Twitter or X. They included posts from physician and industry accounts, whether the promoted product was explicitly named or implied. And this was a small study of only 28 physician endorsers in the year 2022. 75% were in urology, medical oncology, or radiation oncology. They used the median H index to determine whether they were academic, and the median H index was only 15, and more than 2/3 had an H index of less than 20. So these are mostly non-academic doctors. Half the endorsers had no publications related to the endorsed drug or device. 2/3 were sponsored physician testimonials, with half having no disclosure of compensation. They figured out a specialty-weighted mean of general payments received in 2022 across all physicians, and it was $4,500. More than 90% received payments from the endorsed products company. So my comments: take a look at this letter. It's short and good on JAMA for publishing this sort of data. I was part of a recent letter that I've discussed previously documenting high percentage of doctors who receive money from industry, as well as we also found a serious skew in that some doctors receive a lot of money from industry. Well, social media is another new source of advertising. It's especially useful for industry to enroll doctors as spokespeople on social media. And I want to say that though this study does not focus on cardiology, I mention it on this podcast in hopes that it creates awareness of a trend I think is pretty unseemly and borderline unprofessional. And that is this trend in cardiology for industry to take pictures with us and post these online that we did our first or our 100th or 500th procedure with the company's product. These pictures includes the shiny, happy industry people and the doctors who stand in front of a company logo. I am not against industry collaboration, but we should be mindful of being used by industry. And social media is another easy way that industry advertises. Sometimes, dare I say often, advertising products with a dubious benefits or cost efficacy. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. If you like this podcast, please take the time, give us a rating on whatever podcast app you use. That helps others find us. If you disagree with something I say, write a comment on the heart.org website. I like to see these comments. I learn from them. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.